So good morning, everybody. This is a 61-year-old physician, diabetic, hypertensive, hyperlipidemia,
We don't
heavy
see the
smoker,
slides. Can't we see the slides on the screen?
heavy smoker.
Yeah,
Yeah.
good. Yeah, perfect.
So, yeah, 61-year-old male physician, diabetic, hypertensive, hyperlipidemia, and heavy smoker presented with severe chest pain, 2 hours duration. ECG showed ST elevation in the anterior leads. Hemodynamically, he was okay. And echo showed the regional wall and ejection fraction was 45%. Hemoglobin was okay, GFR was good, HbA1c 7.7 and LDL was 3.4. He was loaded with aspirin, clopidogrel, atorvastatin, and he was taken up for the primary PCI. So right radial artery approach, unfractionated heparin of 7,000. The RCA, circ and ramus, there is no significant disease. The left main, there was distal tapering. Then the LAD appeared to be a small caliber vessel with a very acute angle takeoff and proximal total occlusion with thrombus after an early long diagonal. So then XB3 and BMW 2 into 15 millimeter semi-compliant at 14 atmosphere established 3 flow. The LAD appeared small caliber, calcific even after NTG, and it was further dilated with NC 2.25 into 20 up to 20 atmospheres. Then the stent 2.5 into 28 drug-eluting stent was unable to negotiate that because of the severe tortuosity and with the guide catheter backing up. So cutting balloon was used and up to 12 and but could not help in taking the stent further. IVAS catheter was out of stock. The guide extension catheter we took, and you can see here still it was unable to negotiate the tortuosity and the guide was backing up. So then I thought we can shift to the right femoral for a better angle and negotiation with the guide extension catheter. Still it was not going. And then I tried the BAT technique, which is balloon assisted tracking, where you use a 2 into 20 millimeter balloon at a nominal pressure and which is kept inside the guide extension catheter, and then you push the guide extension catheter over the inflated balloon. So it could negotiate a bit, you can see in the first picture, but still it was not reaching the lesion where we wanted to stent. And then there is the blast technique, sliding technique, this one, where you inflate to a half of the pressure, nominal 4 atmospheric pressure, but the balloon is kept outside the guide extension catheter, and while deflating, you push the guide extension catheter. So this is called inchworm technique. So where you inflate it outside the guide extension catheter, while deflating, there will be a suction effect, and this will move further. So finally, it could reach the target and could place the, you can see the angulation, so much it is, because of that tortuosity, everything is coming out and post-dilated, and this is the final result with the stenting. So 1 year follow-up, patient is doing well. So what are the take-home messages? The guide extension catheter is mother and child catheter, can be delivered deep into the coronary arteries, provides increased support, and whenever there is calcified tortuous lesions, the stents can be taken, and it is like a rail, it will form like a rail, it will remove the razor effect. There is a razor effect whenever there is calcium or tortuosity, your guide or the stent gets stuck at the edge of that arterial wall. And these are the two techniques which are described, which is better than the distal anchoring balloon technique which we were using before, because never to take a guide extension catheter without a balloon in front. Otherwise it will cause dissection. Thank you very much.